I'm very excited today because I think I call this like sort of back to some normal discussions outside of COVID. So we have two speakers today. We have Dr. Erin Jenkins, who did her medical training at the University of Nebraska and her residency in internal medicine and in GI and hepatology and nutrition at the University of Chicago. And she is currently an assistant professor at GI at Creighton University. So we're excited to hear from her an update on colon cancer screening because there's been some recent changes. And after we hear from Dr. Jenkins, we're going to hear from Dr. Trahan on lung cancer screening. Dr. Trahan did her medical school at Creighton University, and then she has her internal medicine and radiology residence at St. Joseph's Medical Center in Phoenix. And she went on to complete a cardiothoracic fellowship program. So we have Dr. Amy Trahan in Phoenix at Creighton and a Creighton faculty, and we have Dr. Erin Jenkins, who is in Nebraska and is a Creighton faculty member. So we're going to start off with Erin. Thanks for joining us, Erin, and I look forward to hearing from you.
Hi, good morning or good afternoon, depending on where you're located. So today, as mentioned, I'll be talking about colorectal cancer screening in a post-COVID world, especially reviewing the newer U.S. Preventive Services Task Force guidelines. And just to note, they were released in draft format in the fall, and we expect them to be finalized mid-year. So some of these recommendations, insurance carriers might not completely pick up until they're completely finalized. Next slide. I'd like to start off right away with the case discussion. This is a 46-year-old gentleman who I met in the colonoscopy lab in February, who had presented to his primary physician with rectal bleeding. He does have a past medical history of hypertension and obesity, and he's a former smoker, quit about 10 years ago. He's married with 3 school-aged children, and he has no family history of GI disorders. When he went in to see his primary physician, his hemoglobin was 15 at the time. And if we look at timeline, the bleeding started sometime in the summer, and he waited a couple months to seek care, thinking it might be hemorrhoids, hoping it would go away. And then he saw his physician in October, and his physician very astutely and promptly ordered a colonoscopy. He wasn't fooled by that normal hemoglobin, but then unfortunately he didn't schedule and have his colonoscopy performed until February 2021, because the fall is really when our numbers were peaking here from a COVID standpoint in Nebraska. Our hospitals were at capacity, many elective cases were being delayed, and even though we were still doing diagnostic colonoscopy, a lot of patients weren't comfortable coming in. If you could click next. So here is an image of what I saw at colonoscopy, that erythematous area that's partially obstructing sigmoid colon cancer mass. And I did clear several other polyps from his colon. So unfortunately, this is adenocarcinoma, and tumor testing showed that it was a sporadic cancer. It's not Lynch syndrome or genetic syndrome. And then luckily, CAT scan didn't show any metastatic disease. So he was able to go on to sigmoidectomy or hemicolectomy. And at hemicolectomy, they did find that 1 lymph node was positive. So he's classified as stage 3 or regional disease. Next. So looking at survival by stage, he's regional disease. He still has a great chance for curative intent. He's undergoing chemotherapy right now, but I would have loved to have diagnosed him at a stage 1 or ideally a precancerous stage, especially the impact it's having on him and his family. And so our newer guidelines are now recommending starting colon cancer screening at age 45. So this certainly would have put him in a better stage at diagnosis had we started screening at 45 in this gentleman. And it's hard to know how much the COVID delays of a few months, if it impacted his stage or not, but we do know there's been a 30% decrease in colorectal cancer diagnosis last year between March and November, and an 80% decrease in colonoscopies. So these colon cancers are there and they're being diagnosed at a later stage. And the National Colon Cancer Roundtable thinks we could have an excess of 4,500 deaths over the next decade from delayed screenings related to the pandemic. Next. So jumping right into the guidelines, I highlighted in yellow the major changes. So the major change is that the task force is now recommending screening for colorectal cancer with a menu of options beginning at age 45. This is a grade B evidence, so moderate evidence that there's at least moderate to substantial benefit. They did not change the recommendations for screening in the 50 to 75-year-old age group that has level A recommendation. And they also didn't change the age at which we stop. So We can selectively offer screening to some patients in the 76 to 85-year-old age category, especially prioritizing those who are healthy with minimal comorbidities, and especially if they've never been screened, it's higher yield. They did comment specifically on the Black American population, and basically recognizing that there's a higher colorectal cancer incidence and mortality, and recommending starting screening at age 45 in this group, as we are on all patients, but also recommending an increasing screening efforts in this community, and further research is needed. Next. As far as the menu of screening options we can offer, this also hasn't changed. The task force doesn't prioritize any one screening method over another. This is different from our GI societies, because our GI societies prioritize offering colonoscopy and annual fit testing, and then offering the other methods that people decline. But task force recognizes that different options are good for different patients, and we can offer all of them, other than there's not yet enough evidence to recommend blood or urine testing or colon capsule, but that could change in the future. Next. So let's review the colon cancer trends by age, as this really explains why we're moving the screening down to 45. So if you look on the graph on the left, the purple line is colorectal cancer incidence in the over 65 group. And that has really been declining since the 90s due to effective colorectal cancer screening. But there's been a slow uptick in colorectal cancer incidence in the under 50 age group. And in fact, there's been a 51% increase since 1994 in colon cancer onset in under 50. And this has especially been true of the 40 to 55-year-old age group. And this risk is increased by birth cohorts. So each decade somebody is born after age 1960, there's increased risk of especially rectal, but all colorectal cancer, compared to the risk of early onset colon cancer that their parents had if they were born, before 1960. Next. So again, the data behind starting at age 45, basically the task force is considering benefits versus risks and not costs, but there are some cost analysis that show it is cost effective. And they based this data, the evidence is based on modeling, because there are very few randomized controlled trials that ever included the 40 to 50-year-old age group in screening trials. Now, the life year gain, it depends on what model you're looking at, but we think that we could prevent 2 to 4 cancers and 1 to 2 deaths per 1,000 person screens in this 45-year-old cohort. We also know that age-specific incidence at 45 for colorectal cancer that they were seeing in 2014 is similar to the age-specific incidence that we were seeing in 50-year-olds back in 1993 when colorectal cancer screening was taking off. So it makes sense that we would move our screening down if it's a similar incidence to what we decided was acceptable for a starting age back in 1993. So that age-specific incidence is about 30 to 100,000 at age 45, but it's increasing with time. And depending on what model you look at, we think we could prevent 11,000 to 29,000 cancer deaths over 5 years if we start screening in this cohort. Next. So why do we have this early onset colon cancer, this epidemic? And most of it's non-hereditary. So of these younger people with colon cancer, 80% is non-hereditary, 20% is genetic. So we know that obesity plays a huge role. We know that smoking plays a huge role, and smoking increases your risk even years after you've quit. There's also newer association studies linking sugar sweetened beverages, especially fructose and other refined sugars, with adenoma and cancer increases. There's also associations between red meats and processed meats, and there could be other factors that are currently under research, such as widespread antibiotic use affecting the microbiome, our Western diet that's low in fiber, but we really don't understand it, and it's startling. There's more research, but we don't fully understand it at this time. Next. So I would like to summarize that the cancer incidence is decreasing in older Americans, and that's due to highly effective colorectal cancer screening, but cancer incidence is increasing in the younger age group. And the task force has found evidence that we should start screening at age 45, and we can offer a range of screening options depending on the values that our patients have, when they look at risk and benefit and burden of testing. We know that we need to be vigilant for symptoms in our younger patients and refer them for diagnostic colonoscopy if they have symptoms, even if they're in, under the screening age. And we know there are need for increased efforts to catch up after pandemic-related drops in screening, especially in our communities with high rates of colon cancer burden, where there was low uptake of screening even pre-pandemic. So this includes our Black Americans or Native American populations, or there may be specific communities local or close to you that are low in colorectal cancer screening that we need to really increase our efforts in. Thank you.
Great, great. Thank you so much. So next up, we have Dr. Amy Trahan to talk about lung cancer screening and the updates from the U.S. Preventive Task Force. Dr. Trahan?
Hi, thank you so much. So yeah, we will briefly talk about the U.S. Preventive Services Task Force update, which was just released in March of 2021. Next slide. So just general basics, which most of you are very familiar with. Lung cancer is the second most common cancer diagnosis in the US, but the leading cause of cancer death. And the numbers there, 223,000 diagnoses and 135,000 deaths from lung cancer in 2020 alone. The primary risk factor is cigarette smoking, although we are seeing an increased incidence of lung cancer in non-smokers. Still 90% of the cases are related to cigarette smoking. The overall survival rate for lung cancer is pretty dismal, 20% overall, but this is partly because of the diagnosis of lung cancer is delayed, and so they are later stage. If we can catch those cases early stage, you can see the stage 1 5-year survival rates range from 73 to 90%. So that's a group that we are targeting with screening. Screening with low dose CT, which is what LDCT stands for, has been shown to decrease lung cancer mortality. Next slide. So the 2021 new recommendation statement replaces the 2013 recommendation statement. The new recommendation statement is based on a systematic review of approximately 223 publications, including 7 randomized controlled trials. The 2 largest are the NLST, which is the older study, which included 53,000 patients, and then the newer Nelson study includes 15,000 participants. They also did a decision analysis modeling using the CISNET network. This lung cancer screening is a B-level recommendation, which Dr. Jenkins showed the definitions of those in the prior talk. Next slide. So why, what spurred the update? 2 big things is the release of the Nelson trial data. This trial, as I said, was the second largest RCT and was released in 2018. And so the review of all that data to add to what we knew from the NLST. The Nelson study showed a 26% decrease in mortality with screening versus 20% from the NLST. So increased mortality and confirming the NLST data. Interesting in the Nelson trial, which is information that went into the recommendation statement, is that 1/4 of their patients were actually under the age of 55 years. So younger patients were in this study. And also they had a lower PAC year history as compared to previous data. The number needed to screen to prevent 1 lung cancer death came out as 130 in the Nelson trial compared to 323 in previous data, which has to do with the longer length of scan time and data collection. Also, there's new data coming out that addresses healthcare disparities based on race and how they pertain to screening eligibility, particularly in the Black and Latinx community, where there are higher rates of lung cancer with less PAC year history and at younger ages, which the recommendation statement also tries to address. Next slide. So what are the differences? Very briefly, so the 2013 recommendations, there's this little monogram that they use, but A is for annual, 55 to 80. So the 55-80 is for the age range. The PAC year history is 30, And then the patient has to be a current smoker or has quit within the past 15 years. So that was 2013. The only changes are that in the 2021 recommendations, the age range has been lowered from 55 to 50. And the pack year has been lowered from 30 pack year history to 20 pack year history to be eligible. Annual screening and either a current smoker or someone who has quit within the last 15 years are unchanged. Additional considerations are that you discontinue screening once the person hasn't smoked for 15 years if they've been screened, or if they develop a condition, not lung cancer, that substantially limits their life expectancy, or in a patient who would either be unable to or unwilling to undergo surgery, because that really is the main option. And so those criteria need to be met. Next slide. So in implementation, this has been the difficulty with lung cancer screening and will continue to be. But for implementation, key features, there needs to be smoking cessation counseling going on. Prevention and smoking cessation is going to be our most important tool to prevent lung cancer, no matter what other screening we're doing. Shared decision-making, where the discussion of the benefits, limitations, and harms is had with the patient before they go to screening. Ideally, you would refer the patient to a center that has experience and expertise in lung cancer screening. And then this center would be using some kind of standardization. What we use in radiology is the LungRads program. So this is it's a very busy, colorful table, but it breaks down every nodule, anything we might find by size, whether it's new, old, has it grown, where it's at in the lungs, any other features, and then gives specific recommendations for what to do next. This helps in discussion, it helps standardize how we're following these patients, and it decreases the false positive rates as well as unnecessary interventions, which is very important. Next slide, please. Now the harms of screening and treatment, the new recommendation statement spent a lot of time on this because this is a big concern for good reason. So for false positive results leading to unnecessary tests and invasive procedures, the NLST reported a 26% rate of false positives on the baseline screen. That number goes down with subsequent screens, and under 2% for invasive procedures for those false positive rates. The LungRads criteria was not available at that time, but going back retrospectively and going through the data, just using LungRads was shown to decrease false positive rates at baseline screens to 12.8%, and also decrease the number of invasive procedures by 23%. So that's key to protect the patient from that harm. Radiation-induced cancer is a big issue in the media. Part of the problem is this is all estimated risks, and we don't have great data for how this is going to play out. So more to come. But low dose CT, just to give a general idea, the range for radiation dose is 0.65 to 2.36 millisieverts. And if just being alive in the United States during the year, just going about your normal business, you'll receive 2.4 millisieverts of background radiation. So that kind of gives some kind of framework for what those numbers mean, which helps with discussions with patients. Again, we don't have good data. Everything is with estimations and modeling. But at one of the modeling studies estimated that the lifetime risk that there is a lifetime risk of 2.6 to 8.1 major cancers per 10,000 people screened after 10 annual screens. Next slide, please. Overdiagnosis is a big one. And unfortunately, there isn't a lot of great data. Hopefully this will, again, more to come. But the CISNET did do a modeling study that estimates 6% of the screen detected cancers are in that category of overdiagnosis if we use the 2021 screening program. Incidental findings, big range depending on what you classify as incidental, which has not been consistent in the past. And you can see there 4 to 40% have, quote, incidental findings. But Some of these are very important. And for example, in LST, 0.39% of patients in that LDCT group were diagnosed with kidney, thyroid, and liver cancers. And I'll just say last week, we had a lung screen that was negative for nodules, but the gentleman in the last year had developed several liver masses that look like metastatic disease. So now he's getting his workup for that. And then increased stress and anxiety has been reported, but that's really just in the short term while people are waiting for the results, which is a very, within a week or less for our program. Next slide. Okay, so super brief. We started our program in 2011. We've screened over 2,100 patients. I think the big key is that wherever this lung cancer screening is being performed is that you have a multidisciplinary team, which obviously is difficult in the implementation process. Here we have pulmonology, radiology, thoracic surgery, oncology, infectious disease, and family practice all involved in the screening program. And next slide. Last slide, just for what's happening in the real world and also how COVID has played into this last year, because our screens have absolutely declined during 2020. So this is a 60-year-old female. So she fits in that 50 to 80 year age range for eligibility. She has a 37 pack year history, so greater than 20 pack years. And then she had quit smoking 4 months prior to undergoing her baseline screen. So on the left-hand side of the screen, in August of 2020, you can see there's a small nodule there, about 10 millimeters. She was recommended, we use lung rads, she was recommended for a 10 millimeter nodule to have a 3-month follow-up chest CT. She did not return at 3 months because of COVID. That was our time for being right in our peak, and she was worried about coming in and having that done at that time because of COVID. So she ended up coming in as numbers started to decline. And so she ended up coming back at 6 months. And you can see that nodule is it has doubled in size, has some small bronchial dilatation associated with it. And so at this point, guidelines are to biopsy. So she went to our interventional pulmonologist and had a biopsy, and this is a non-small cell lung cancer. Luckily, she's had her EBUS, her mediastinum lymph nodes have been assessed and they're negative. So she's on the schedule to have a partial lobectomy to remove this, and she'll be in the stage 1 category. So we'll have a good 5-year survival rate. And that's the end of my discussion. Thank you.
Great. Thank you very much. That was excellent. So John, you're going to keep us in this format, right? So that'd be nice for the panel conversation.
Yep.
Great. These are two, Gary, these are excellent. Really very good. Thank you so much. And very timely. It sounds like both of you have described a drop in screening since COVID. And I know Dr. Trahan, yours was a follow-up, which is sort of a dramatic, thankfully didn't go too long. I guess, Dr. Jenkins, are there specific things you guys are doing at Creighton and in Nebraska to encourage people to come back in? And how are you guys thinking about this right now?
Yes, so that's good you bring it up. And our newer American College of Gastroenterology guidelines that also just came out, they're also recommending that as a system and as physicians, we start doing more programmatic colon cancer screening efforts instead of just opportunistic. So not like, oh, patient showed up in my office, come in, what can we do, programmatically to increase it. So we are trying to send out a blast. We're drafting a letter that is going to go out through my chart, through the patient portal to everybody of a specific age range. And I'm not sure, unfortunately, I don't know the details behind this. My office manager is on it, but
that's okay. But you're targeting an outreach,
right? We're an outreach where we're just describing the methods we're doing to keep people safe from COVID, reminding them that there's been missed screenings related to COVID, and encouraging them to come in. That's the main thing that we've done. And then in addition, just our schedulers just combing the lists and calling people back, and on a one-to-one personal level, trying to explain to them that it's safe.
Great. And I think, Gary, did you have a question? I cut you. I think I just cut you off.
No, you didn't. But I do have one question.
Dr. Jenkins, when you talked about the incidence of colon cancer and you mentioned I think it was Black male patients, you talked about an increased mortality from late disease. And I also think I caught that there was an increased incidence. And my question is it just that people are diagnosed late and we're not finding them, or is there an actual per capita increased incidence of colon cancer in Black males?
So there is an increased incidence, but it's thought that much of it is related to, because with good colorectal cancer screening, we actually prevent the incidence and onset of colon cancer. So if people are missing screenings, they're going to have a higher incidence because we're not clearing their colon polyps. But there are probably other social determinants of health in addition to screening. So whether it's diet, those environmental factors that are social determinants of health. So it's mainly screening, missed opportunity screening, but other factors as well.
Great. Dr. Trahan, can you, I mean, one of the things, as you and I were chatting beforehand, I did some of my research in overdiagnosis and screening, and early on, lung cancer was kind of the poster child for overdiagnosis and false positives in its early infancy, and it's now corrected itself. To me, the key, as a general internist or primary care doc, is who gets screened, right? It's really, I mean, I like the A 50-80-20-15 rule. The problem is a lot of people break the rules or don't follow the rules, and you end up with a lower prevalence of folks getting screened, hence more false positives, hence more overdiagnosis. You want to comment a little bit about that?
Yeah, I completely understand the breaking the rules part, and that has been difficult in implementation, and as lung cancer screening in general is difficult in implementation. I think the focus has to be really on sending patients to a lung cancer screening program. We have had to say no, and we have had to have discussions and really talk to people because there definitely is that worried well component sometimes where they don't qualify for a screen. You don't want to obviously upset the patient, but that we do have a physician who will meet with patients who do not meet criteria and have that discussion to kind of calm that anxiety, let them know why, and hopefully that maintains that relationship.
It sounds like you have a good interdisciplinary team that works together, which I think is critical, right?
Critical.
That's really, and I love that model.
Absolutely.
Love it.
A fabulous nurse coordinator or nurse navigator coordinator, a family practice doc who's amazing. All the team is absolutely necessary to make it happen and do it with guidelines, following guidelines, and doing the right thing.
Got it. Excellent.
And do we have a feel across CommonSpirit? I mean, I think this is really unique in Phoenix and, a great program. Do these exist in other parts of, and you may not know, for CommonSpirit, but
we should know, Gary.
Yeah, no, I mean, I think we should find out.
No, but I think it's a great, I think all of the things we're talking about today, I'd love to see, Dr. Greensweig and I are talking about creating clinical standards for CommonSpirit. And I think what you've demonstrated, particularly with the changes in the U.S. Preventive Task Force recommendations, we need to think about that across our entire health system. Do you have a sense, Amy, of what is happening in other regions within CommonSpirit, or no?
I really do not. To be honest, I am the brand new director here of the program.
Oh, well, welcome.
So I'm just entering the administrative side of it, and so I do not know that information. But we did just undergo an audit of our program that came from CommonSpirit. And so we're going to engage in that process, obviously, and then where that came from and how we can participate in.
Well, I think Gary's going to probably call you.
Yeah, no, I think we need to know. I mean, these things feel as though they're in academic centers and so on, and so where we don't have that sort of group of resources together, it'll be interesting to kind of look and see. You also mentioned that for folks with 10 scans, that the rate was between, I think, 2.6 and 8 per 10,000 patients. but do we have something to compare that with? Like, what's the background rate if the person hasn't had 10 scans?
Right. So we don't. The problem in general with radiation-induced cancers, I mean, obviously, we haven't been scanning people the way that we scan just in general, not just with screening, but obviously in the ER and, everywhere. As, the last 25 years, right? Hopefully we'll start seeing data and how that's being processed. But honestly, everything is theoretical when you were talking about radiation-induced cancers. A lot of the data is based on Nagasaki and Hiroshima, where we had huge amounts of radiation that people were exposed to and then extrapolated. So it's difficult to know, but hopefully, more real data will come out over time as we track these patients and their exposure.
Well, Gary, I think we should probably wrap up. Marika Gray from the Southeast region said that they have an ongoing program and they actually have a mobile van that does outreach. So I think we're going to start connecting the dots with everybody and make sure that we can share best practices. Well, I really, both of you did an excellent job, really impressed. And we're going to be tapping into your expertise, right? Gary, I think helping us
we have your name.
Change our algorithms across the country, and therefore your influence will be spread further. So thanks for joining us. Any last words, Gary?
No, thank you. Great. Thanks for helping us pull this together. We really appreciate it. It was just perfect. Thank you so much.
Thank you.
Thank you so much.
Thanks for all of our listeners.